and we usually have to go take him and bring him to where he needs to be. So I'm impressed you are here with us. Thank you. But anyway, Dr. Gordon graduated in 1990 from Southern Illinois University School of Medicine. He continued his education at SIU, where he completed his residency in general surgery in 1995 and completed his cardiothoracic surgery residency in 1997 from State University of New York at Buffalo. And he is a hometown boy. Actually, you were born and raised in?
I grew up well, but my grandfather was in the barbershop on 95th and Western.
Oh.
And they should take it at like 79th Western. Right where St. Rita's across the street. And my mom was kind of my dad was St. Rita, and my parents were married at St. Thomas More, right? Not too far away from both more at both company.
You know the neighborhood. That's the neighborhood. And the neighborhood knows him. He's great to have. So Dr. Gordon has been in practice for more than 22 years?
I'd say I've been in practice for 25.
25 years, okay. He's certified in general surgery through the American Board of Surgery and certified in thoracic and cardiac surgery through the American Board of Thoracic Surgery. He's well published and he is a highly respected surgeon throughout the Chicagoland area. He's holding privileges with many hospitals, inclusive of Advocate Christ Medical Center, Advocate Health Suburban, Trinity, and many others.
Yeah, most of them.
Okay.
Yeah,
I'll let you start on that.
But yeah, the majority of what I do is at the price, but I have operated at both Trinity and South Southern Pitch and something a bunch of other hospitals in the pitch. Thank you so much for coming out on a little bit of still a little bit of a rainy, cold evening in Chicago. A very open discussion here. I'll kind of tell you a little about lung screening, a little bit about the way we approach lung cancer, and then if you have questions during it, don't hesitate to raise a hand. I'm glad to just have an open discussion about things. And then if you want to hold questions at the end, that's fine too. But if you have a question like with someone else in the audience, whether here or online, has the same question, and we'll get it answered. So don't hesitate. So it's
left click. Yep. There you go.
So lung cancer is a major problem as far as the morbidity and mortality in the United States. So if you add up the next three cancers, cause of cancer death, prostate, breast, colorectal, they won't equal the yearly death rate from lung cancer. And that's basically about 160,000 people a year will die of lung cancer. To put that in perspective, it's kind of the equivalent of a fully loaded 747 crashing every day of the year. So it is a major source of morbidity and mortality. And we've always kind of tied it to smoking, but really the incidence of non-smokers having lung cancer is really been on the rise the last several years. So it is not just a disease of smokers and afflicts many Americans. So lung cancer overall has not had a great survival. And the reason being is that many patients present at advanced stage. So we know early stage, the blue stage is early stage lung cancer. And we know 5-year survival rates can be up around 80, 60 to 80%. So if we can find people early, we can cure them. Unfortunately, we don't find a lot of people early. And that's really the challenge. And so there have been many efforts over years and years to try to basically become better at finding people early. So why should we screen for lung cancer? Well, what we need to do, we know the survival is better if we find people early. We just need to find people earlier. And one way to do it is to do screening. That's what we do for breast cancer. That's what we do for colorectal cancer. And now that's what we do for lung cancer. And the reason being is this, is that what our goal was, so this is the normal distribution of the presentation if it's only on symptoms. If all you're doing is waiting for someone to get symptomatic, this is the presentation of disease spread. So These are patients with stage 4 or distant disease. You can see if you go by symptoms, it's the vast majority of patients have advanced stage disease. Now, if you look at it based upon screening, you see that there's many more, these are the early stage 1, there's many more early stage, and there's a lot less of the advanced stage 1 to do screening. So that's really our goal, was to try to make that happen. So the rationale behind one screening was, one, we know early, people we find it early, people do much better. Overall survival rates is 17% overall. But for early stage 1s, it's 60 to 80%. Two is that we knew that if we could change people's smoking habits, we could decrease the morbidity and mortality of not only other smoking-related illnesses, but lung cancer. So there's actually a combined program. When you get screened for lung cancer, you also go through a discussion of smoking cessation. Since about 85% of our lung cancer do still occur in smokers, we know that if we address that would diminish the amount of people who succumb to this disease too. So that's an important part of screening, is smoking cessation. We also know that smoking cessation is not that effective on a year-to-year basis. Only about 20-35% of people stop smoking when they go to the smoking program. So we also know if we keep addressing that each time a patient gets screened, we realize that we will increase the number of people who stop smoking. So maybe we should just concentrate on just stopping people from smoking. Well, the reality is that the cancer risk doesn't drop for about 15 years after you take the last cigarette. So we also know that we need to continue to screen, even if we get people to stop smoking, for the simple reason that smoking still leads to cancer after you stop for about 15 years. It may be longer now. We're starting to think it could be as long as 20. So a lot of attempts were made over the years to try to find a good way to screen. The vast majority were not successful. None of them were really significant decreases in morbidity and mortality. Why were they not effective? The big one was that they used basically chest X-ray. While you can find in today's CT scan like a little 4-millimeter nodule, 1/8 of an inch, you really needed something that was almost close to a full inch to see it on chest X-ray. So patients were much further along. The other thing is we had not honed in on that group that would likely be affected by finding the cancer, or in other words, they identify patients who could be treated for the disease. So if you screen all smokers, you may find that patients that are really not medically able to undergo therapy. So that was part of the reason that these studies weren't effective. So basically, they did a huge trial, and that huge trial was 53,000 patients. At the meeting this was presented at, I was actually a paper right in front of them. So there were a whole bunch of people there, but maybe they hear the paper after mine. But anyway, these patients were followed. They were either randomized to get yearly chest X-rays or yearly CT scans. And they had set up criteria for that. And those criteria were this: that to be included, you had to be between 55 and 74. Why is that? Because they wanted to look at, we know that the risk of cancer goes up with age. So they wanted to get a higher risk group where they were more likely to have cancer so that they could impact greater. And then the 74 number came out, and it was subsequently increased to 77. And now maybe up to 80, we'll see in the next iteration. But the 74 number came out because they wanted to have people healthy enough to be treated for the lung cancer to impact the mortality. Now, who was excluded? Those who had a history of lung cancer before, those who had a recent CT for some other reason, and those who had a weight loss, okay? There were metabolic, and I'll talk more about this. If you were on home oxygen, you were not able. Why was that? Because once again, they wanted people who could be treated, and they would thought they'd be a too high a risk group. The other thing was antibiotics. Antibiotics can show up like it is a show, if you have been treated for pneumonia, it may show up like there's a tumor or mass, when there really is not. So these are the results. And what we're looking to do, like I say, is find patients earlier so that we can treat them effectively with surgery, the majority of surgery, so we can increase the cure rate. Sure enough, when they analyzed it, those patients who underwent the CT compared to the chest X-ray, 40% were stage 1, compared to only 21% that were stage 1 in the chest X-ray. So it greatly decreased that. And then we talked about people presenting with distant disease, spread. The stage 4s were reduced from 36% in the chest X-ray group to only 21%. So it definitely shifted the stage up, and had a dramatic impact on mortality. And that overall effect on mortality was a 20% reduction in mortality, so the death rate. And how effective is that? Well, if you talk to breast surgeons, they'll tell you that the impact of mammography on the mortality of breast cancer was only about 2%. This is about 20% effect on mortality. So it's about 10 times more effective than mammography for treating and curing cancer. So it definitely was a positive study, and it led to the development of lung cancer screening. So I'll go over a little bit who those who are included, but let's talk a little bit about who shouldn't be screened. Okay, and there's a couple big ones. One is if you lost weight. So if you have signs or symptoms of lung cancer, where you're coughing up blood, hemoptysis, you have increase in shortness of breath, weight loss, unexplained, 15 pounds per year, you really should have a dedicated CAT scan and work up for that problem. So
But at that point, it's too late, right?
it could be. Now, it could be from other things, but it's not necessarily too late. So some people do lose weight who don't have metastatic disease, who don't spread. But to your point, you're exactly right. It may be too late. So we still saw that about 20% of those people who presented with basically symptoms were still stage 1, but nowhere near the 40% that with the CT scan. So you're right. The chances of you having advanced disease, what are the chances that you have advanced disease in stage 4, more than advanced, but what we call metastatic disease? It's about 55% if you have one of these symptoms, and you can turn out to have lung cancer. Now, if you have one of these symptoms, it's not a 55% chance that you have metastatic cancer. No, what it is, if you turn out to have cancer, lung cancer, if you present just by symptoms, there's a 55% chance. That chance is only about 20% now with screening. So does that make sense? So it doesn't definitely mean that you're going to be too late, but it means that you should have a dedicated CAT scan with IV dye to get a better sense as to whether there's lymph nodes, if there's anything in the liver, get a look at the pancreas, get other causes of weight loss other than just lung cancer. Does that make sense? So, yes. Maybe you have to. Yes.
And such is the life of a physician. They're never,
Totally.
they're always on call.
Yeah.
Yeah. You can kind of go right there. All right, thank you. Okay, no problem. Thank you. It's still the life of it. Unfortunately, there are no small problems. That's okay. That's okay though. So as These are currently for Medicare patients, and unfortunately, so usually Medicare leads the way on these type of things, and they when things expand, they expand from Medicare standpoint. Unfortunately, this is not. So currently with Medicare, and this is a little bit outside, so you can see they increase the range. Remember, it was 55 to 74. We found out, well, we're definitely helping people. Could we help more people? So they expanded from 55 to 77, and sure, looking at the newer data, that did help to decrease mortality, even if you expand things out. Once again, you need to be asymptomatic, no signs or symptoms. Current smoker, still in the last 15 years, and then a tobacco history of at least 25 years. So this was also reduced out from the initial one. And part of it was you had to have, in the initial one, you had to have at least 30 pack years. So a pack year is like, so if you smoke 2 packs a day for 15 years, that's 30 pack years. If you smoke 1 pack a day for 30 years, that's 30 pack years. Or if you smoke half a pack a day for 60 years, that's 30 pack years. So that's how that gets calculated. And you still need to smoke in the last 15 years to get that. So this is actually the recommendation from public health. Okay, so as I say, these don't really jive exactly right now. We're waiting for a ruling to come down from CMS, where Medicare is going to cover this also. But basically, they're at age 50 to 80, asymptomatic, current smokers, smoked the last 15 years and 20 back years. So as I say, things have started to expand out a little bit. And this is how you calculate that factor, as we talked about. Shared decision making is a part of it. You talk with your physician, the pros and cons. Would you want to undergo treatment? Would you want to be evaluated? So that's an important part, and includes discussion of that smoking cessation. This is our lung cancer screening at Price right now. You can see how it's gotten much more popular. This is obviously on a yearly basis now, and we're up to around 750 screens now a year. Obviously, they had a little bit of a flat area during COVID, but it's picking up right now. We've actually found 24 cancers, stage 1, 8 of them were 24, so a third were stage 1, and only 3 of those 24 were advanced stage lung cancers. So they relatively early staging on those people who were diagnosed at Price. As you can see, a total of 2,200 lung cancer screenings have been done to this point at Price. So we were an early adopter to it, and have found to be very successful for our patients. Once you get that done, it goes to a scoring system. That scoring system helps the primary doctor decide what they should do next, because it is with most screenings, things do run to the primary. And it's really these figuring out those stage 4s to get the biopsies.
Is there a simple answer to the difference between small cell and non-small cell?
There is a simple answer. There is simple. So, non-small cell cancer starts in the epithelium or the lining of the airway, and that's where non-small cell adenocarcinoma, squamous cell carcinoma, large cell carcinoma, they all start in the airway. The neuroendocrine tumors, neuroendocrine cells are more like hormone cells in the body. That's where small cell lung cancer starts. So it does start in a different spot, and that's where the difference. Then to that point, the reason that's brought up is simply that they're treated much different. We rarely do surgery for small cell lung cancer. It's usually treated with chemotherapy. Other questions? So we did find 2 small cell lung cancers, which we call limited stage, we're probably treated with chemotherapy, radiation, or together. Okay, so what does that look like for the patient? So here's a CT scan of the chest. Okay, looks pretty clean. There's these little blisters on the lung from smoking, but not too much there. This is year 1, and now you're starting to see this little area right here where it was here, there was not too much there. Now you see this little scarred area, probably about 4 to 5 millimeters. Too small to do a biopsy or anything for, but certainly something we want to keep a close eye on. So because of that area, based on those criteria we saw, that a 3-month scan was ordered. So we didn't wait a whole year. We saw something new. We said, let's get a 3-month scan. see if it's something we need to be worried about or concerned about. Sure enough, it was bigger on a 3-month scan. You do a biopsy, and it's adenocarcinoma, which is one of those non-small cell lung cancers. And so this patient underwent surgery and resection, and did well with that. But that's an example of what we're watching for. It's very subtle, and so those doctors need to be well trained to do that. Now, if you find a nodule, what things can we do to basically discern if it's cancer or not? That patient had a biopsy, and this is just an example of a biopsy. You can see that there's a little nodule right there. This is the needle under CT scan going right into the patient. So that's what that looks like. The patient's somewhat sedated. Twilight is an example of this type. Same needle going in right here on the side. They put a grid down here and do a plan. And then under CT guidance, they can pass a needle. And while the patient's actually on the CT scanner getting the biopsy done, they're actually, the pathologist looks at it right there. Tells you right away whether it's cancer or not. And more stains and things are done, but the bottom line, we know if we have tissue right away. So what's evolved over time is, you can imagine putting a needle in the lung. There's a low risk of pneumothorax for the lung collapsing. What's evolved over time is, can we biopsy nodules from the inside out? And Christ just invested in a new device. It's basically our interventional pulmonologist, and along with us, we can actually look with a bronchoscope at the airways and then walk out a robotic bronchoscope out into the airways to get a biopsy from the inside out. What's the advantage of that is? Much less cancer than a collapsed lung. So what does that look like? So what we're doing, these are the lungs right here, and they're all full, we have airways in our lung. And we can walk the bronchoscope down, and what it does is it creates a magnetic field around the patient. And with that magnetic field, you can actually see where you are in the airway. Just like you're driving along the land, around it, you can see where you are by GPS. Same thing here. This can tell you where you are within the lung. And you can walk all the way out to the little airways with that. And we just invested in a device at Christ called an ION, which is a robotic bronchoscope. It just kind of has come on the market. And you can walk way out into the lung and biopsy. And what's the advantage of biopsy a nodule from the inside out? The chance of collapsing the lungs is basically almost zero. It drops it from about a 10–15% chance to about a 1% chance. So once again, the pathologist is right there. They can look at that area, and as the catheter is going, as we're sampling the tissue out there, they can look at it while the patient's on the table to let us know what it is, and it helps us out turn by turn through the airway to make sure we get to the right spot. And then when we're at the right spot, we use X-ray to confirm it, put the needle through, and do a biopsy from the inside out. So that's really the newest thing. We've had an ION now for about 3 months. It's through robotic scope, and it's been a great advantage for us and for our patients. Now, I think that one thing I should say is that when we're talking about lung cancer, it's not just a surgeon, it's not just an oncologist, it's not just a radiation doctor, it's not just a radiologist, it's not just a pulmonologist. It's all of us together making the best decision for the patient on what to do. So every Friday we get together, and at Christ we have about 20 lung cancers diagnosed a week. So we'll go through, look at all our imaging and everything, and we are use that information to make a decision on how to proceed. We pass that along to the primary doctors, and then our treatment team's there. And I think that's really where the magic happens, when everybody gets together and you have that group thought, and I always think to myself, it's kind of like that the pyramid game where you could ask the audience, you could poll the audience, it seemed like on that show, when you pull the audience is almost always right. They almost give the answer. It's just an effect of that group think that really leads to better outcomes. And it is really a key component of our lung cancer program at Christ. Now, once we find it, for those patients who are suitable candidates, we would take that out. The majority of our cancer is taken out robotically now. So what does that involve? And I'll give you a little warning here. If you're a little squeamish, this does get a little bit operative at today's world of Discovery Channel and everything. I think everybody's pretty used to these type of pictures. So this is what it looks like at surgery. This is what the surgeon sees through the console. And basically there's robotic arms that go in the patient, and then you're at a console and you're working these little small little instruments.
I can go back.
Yeah.
There you go.
So you see these little very minute arms, and they're only about the size of a dime, these little instruments that we're working with. And that's a lymph node. You can see we've dissected it out, taken it out. We do take out the lymph nodes at the time of surgery. Here's the upper lobe of the lung, that's the lower lobe. These are the blood vessels going to the lower lobe. And so we can take these staplers that are hooked to the robotic arms. We can use those staplers to actually divide the vessels. So that's what we're doing right there, is just dividing the blood vessel. And we're very careful. We put a little band around it to try to raise it up so that the stapler carefully goes under it and allows us to dissect that out. And this is all done obviously through very small incisions, much like the gallbladders they took out the scopes years ago. These are kind of the little dissecting tools that we have to dissect that out and dissect out the blood vessels. You can see it there. In the course of dissecting out those vessels, we'll obviously get those lymph nodes out and dissect out those things so that we. It's important to get the lymph nodes out for two reasons. One, they're a filter that will trap that tumor, so we want to get those out. The second thing is that it helps the stage to know if we need chemotherapy, radiation, anything after surgery. We use the that to find it out. Here we are now dividing the lung tissue, and you can see it starting to separate now. The upper lobe from the lower lobe. Really, the lower lobe is where the tumor is. Unfortunately, we can't just take out the nodule, because not only are there lymph nodes around the blood vessels in the center, there's also lymph nodes inside the lung. You kind of see these little black spots around there. Some of those are lymph nodes, and we use that to try to take those out. We also will kind of see us moving the lung over. We'll also take out some of the lymph nodes from the center of the chest, because that's the second place that we go. First place we go would be the local lymph nodes. Second place would be the lymph nodes in the center of the chest. So we dissect out those lymph nodes also. As you can see, these little tools, those tools that the smoke you see coming off is actually a little cautery to burn any little bleeding vessels to make sure. You can see the lymph node, that little black structure underneath there. We're carefully grasping it and then using the sector just to dissect out. And at the same time we're dissecting, we're cauterizing any vessels to it. So
Is that a permanent solution?
that's a good question. So is that
When you
permanent?
go
Stable?
in a year and do it again.
Oh, could you do another robotic case? You're asking somebody or what? Oh yeah, you do a redo robot on some people.
I mean, is it necessary?
Oh, is it necessary? Going very unlikely. The incidence of a second lung cancer is only about 10% patients who have a second lung cancer in their life. So we do follow people for that, and that's one people we follow closely. And those people, it said on their lung cancer, history of lung cancer, those patients are getting followed with dedicated CT. But yeah, you can do a second lung cancer. It's not commonly that I've had patients where I take it out right lung cancer and they come back 5-10 years, sure if they got a left lung cancer, we take that out. Obviously, the same risk factors, so the risk still occurs, but it's only, like I say, about a 10% lifetime risk.
And that's monitored with the CT scan, is that the idea?
That is, it's monitored with a CT scan. I'll tell you, occasionally you find the doctors will order PET scans too, the oncologists. But generally, we're looking for a new cancer. We use CT scanning to look for nodules. So after a lung cancer, so every 6 months for 2 years, then every year thereafter for a total of 5, then we switch it back to screening. We're just looking for a new cancer after 5 years. We thought we cured you of that cancer. And what are those cure rates? Like I say, about 68% of patients are going to be cured of lung cancer from the surgery itself. I would tell you, why is there variability? 68. It really depends on the size of that tumor. So 1 centimeter tumor is closer to 80. If it's a 2.5 centimeter tumor, it's closer to about 60. Why is that? Because about 1 billion cells in that little tumor, with a chance one of those cells is broken off somewhere. So with our new treatments and things, and many of those things we can still treat and cure.
And Medicare covers all those procedures?
They do. They cover all those scans. That's a good question. Yes, they do. They cover all those CT scans. PET scans can be a little bit more variable, and the reason being is so as you know, and you all probably know, maybe better than I, but there's a lot of patients that manage, Medicare, where say Humana or Aetna or somebody has a policy. So there's a little bit of getting those things approved. And but when you talk about the basics, so the CT every 6 months, CT every year, for those 5 years, those things are covered. Sure. So what is that? What does that look like? What's the risk of doing something like this kind of survey? These are our data. This is the last time we were surveyed at Price. If you look at this, we're just looking at what's the chance of dying from this kind of surgery. So the mortality for us and all the patients we saw was 0.8%. How did that really stack up against the rest of the country? Well, we compare ourselves to the top 10%, these high volume institutions. The red bar is the 90-day mortality. This one's the 30-day mortality. Our mortality was 0.8% at both 30 and 90 days. In other words, less than 1% of people died after the surgery at 90 days, compared to across the country where 2% died within 30 days and almost 4% died at 90 days. So there is some morbidity to the surgery itself, but like I say, with a well-structured program that's busy, with all the tools and extras, it really decreases the mortality and morbidity of the surgery. Now, what if you can't have surgery? What if you're just not, you've got a bad heart, you just had a heart attack, you just got stents, you have other medical illnesses that need to be treated. We do have new ways to treat you. And one of those is this is a device called CyberKnife, and that's kind of a new iteration, but we have something called Saber now. And Price is also one of the leaders in the area of Saber. What's Saber? Stereotactic ablative body radiation. In other words, giving a focused beam. How is this different? Well, if you talked to somebody 20 years ago who had cancer, a lot of them had, if they had radiation, they had radiation over about 5 or 6 weeks, Monday through Friday for 5 or 6 weeks. With these kind of precision devices that can actually track your breathing, we can treat you in about 5 treatments. So instead of giving 200 per treatment, we give 1,000. And it's much more effective. The radiation line is much more focused and it's much more concentrated to that one area. And the faster you give radiation, I know it seems counterintuitive, but the faster you give radiation, the more effective it is. So 5 treatments is much more effective than 30. Why? If you give the same dose over 30, but you're breaking it up more, we call fractionation, you're breaking it up more. This one you're giving larger fractions. So this is very effective. Now, why don't we just treat everybody with this? Well, it has one, but as you talk about the lymph nodes, all the lymph nodes you take out, unfortunately, we can't treat all the lymph nodes with that kind of thing. So we do see a little higher incidence of recurrence, maybe about 10% in those lymph nodes. And we do our best to stage the patients as best we can, but it's a very effective treatment, much better than our old treatments for patients with early stage 1 cancer who are not surgical candidates. A lot of times we get the question, well, what is a lung node, or what is a lung mass? Well, a lung mass is about 3 centimeters, so a little over an inch. A nodule would be anything really smaller than that, an abnormality on the skin. So I probably have any other questions at this point? Anything from the crowd? No?
Not yet.
All right, so as I said, we use CT to evaluate these nodules, and what kind of things are we looking for? Well, the size. The bigger the nodule, the more likely it's cancer. Calcium in a nodule generally means it's benign. It's much different than breast. Breast calcification is kind of a hallmark of some cancer. For us, when we see calcifications, we generally think that's histoplasmosis, and it usually is, and so we don't have to worry about it. We also look, for spiculated borders. And then very commonly, we watch for growth. And why is that? Well, the reality is that we're going to find many more nodules when we screen patients than we're going to find lung cancer. The incidence of a nodule in your first screening, if you've been a smoker, 24%. The incidence of cancer amongst those patients, 1%. So for every 24 nodules, we find a cancer, basically, is the way statistics work out. So that means we can't be too aggressive going in and take out every nodule we see. We have to follow those CAT scans and see if they grow. And that's part of that whole process of that grading I showed you, 1 to 4. Their growth is thrown into that mix to give us a better idea on how to proceed. Because one thing we don't want to do is over-treat the patient. When I talked about, all the sitting around the table looking at that, that's the real advantage, is that everybody's looking at that and saying, okay, what is the chances that this is a cancer? Should we biopsy it or not? Because everything we do does have some risk to it. So we do our best to minimize those risks, but we don't want to be overly aggressive. There are a lot of benign causes of nodules. These are a whole bunch of them: hamartomas, lipomas, vascular, IV we call arteriovenous malformation. There's a whole host of things that could be things other than cancer. So you can't biopsy every one of them, and you can't take every one of them out, because at some point you're going to hurt more people than you help if you're taking out benign nodules. Because there are complications. You have blood clots. People have pneumonias. People have other complications of surgery, and we don't want to be taking out every nodule. We really want to follow those factors. What helps us decide? Should something come out? One thing is the PET scan. Something lights up on PET scan, it makes us think it's metabolically active or it's growing fast, and it tells us much more likely to be a cancer. So it's one thing we use frequently is a PET scan to try to help us discern if something is cancer. As I said, there are different kinds of malignancies. The majority of what we're going to take out are these bronchogenic carcinomas. There are kind of other lesions. They can be metastatic lesions that come from other tumors that we can find. The other thing that we should say about lung cancer screening is that sometimes you find other problems. You find a tumor that's not lung cancer, a thymoma, a neocellular tumor. You find an aneurysm. You can find blockages in the heart arteries. There's other things that you can identify and help to impact someone's life. There is a free virtual smoking cessation. You can kind of take a picture of this, and I think this is on the Advocate website. You can log on to this, but they do have a smoking cessation program that they run through Christ that people can sign up for. And as I say, that's an important part of screening is having people stop smoking. So I would be remiss if I didn't say that. So a key component to this whole process is our nurse navigators, who go through all these screenings and pick out those that we need to review at conference. As you've seen, there's 2,200 screening CTs that have been performed. So someone's got to go to that data, and Katie, Tracy, Diane, our nurse navigators are just a critical component of that. And the treatment of lung cancer is really involves many specialists from many different disciplines, all coming together to try to get the best out. Thank you so much for your time and everything and coming out, and I'll be glad to answer any questions.
Hi. My primary never recommended a lung screen. I haven't seen him about 35, 40 years. He's on staff at Christ. He used to have an office in the old Thunder.
Yeah.
Never. The only thing he recommends Once a year, we get the labs, and every 4 years, colonoscopy. I never recommended, your presentation was excellent. Next time around, I'm gonna ask them about
And what's your, can I ask you what your smoking history is? What,
it. I don't know.
oh, so here's the thing, is that to meet those criteria for lung cancer screening,
Yeah.
they only apply to those patients who have smoked for 30 pack years. So non-smokers, there's not, right now, there's no benefit to screening. Why is that? Yeah, 85% of lung cancers occur in smokers. And that whole trial that was done only about people who had at least 30 pack years smoking history.
Could you clarify 30 pack?
Yeah, what's that?
Sure, let's go with 30 pack years one more time. So 30 pack years, what is that? So if you smoke 1 pack a day for 10 years, that's 10 pack years.
Oh,
Okay, so you've got to smoke 1 pack a day for 30 years, okay, to be eligible to be screened. So
Or
30
2
pack years.
packs a day for 15 years.
Correct, or 2 packs a day for 15 years would be 30 pack years. And and that's gonna, you know, that number is being reduced back. Back up slides real quick.
Yeah. You tell me when.
Okay.
Okay.
Let's go
One
Let's go
more.
one forward, okay? So this is the current Medicare data. So if you're a Medicare patient, this is the current data. This is the current criteria to get screened, okay? You've got to be between the age of 55 and 77, all right? You've got to have no symptoms of lung cancer right now, no coughing up blood, no shortness of breath, no weight loss. You've got to be either a current smoker, okay, so you've got to be smoking now, or you've got to smoke in the last 15 years. Why is that? Because after 15 years, your risk of cancer is almost down to a non-smoker. So they really require for you to be smoked the last 15 years. And then currently the 30 pack years of study was done on, has now been reduced to 20 pack years. Why is that? Because we find out that cancer is prevalent enough, common enough within patients who have a lesser smoking history. When the study was done at 30, we found that even 20 was enough lung cancers where screening makes sense and would still save lives. So that's why your doctor never asks. You got a great doctor doing the right thing.
that's what he said.
It's good of you to say that too.
Right?
Yes.
What about Radon?
Radon, that's a great doctor. Radon is probably more than smoking. When you look at non-smokers, probably the most common cause of radon. Now, what is radon? Radon is naturally occurring radiation emissions in the soil. When you dig up, most commonly the foundation for a home, you can many times disrupt this and release the radon. All right. If you bought a home, I would say in the last, in my sense, it's probably 30 years or more, you have to get a radon test. It's required, I think, when you do your transfer of deed and all that. What are they testing for? They're basically usually testing your basement to see what your radon level is. If you have elevated levels of radon, of which I actually do in my basement, they have a mitigation system that goes in under your foundation, and it mitigates the radiation, the effective amount of radiation by basically passing through, so it's not absorbed up. And actually throw a monitor right in your basement that tells you what your radon is at any moment in time. So why is it important? Radon, the amount of radiation in radon, especially if someone's got a bedroom in the basement or something, the amount of exposure to radon in the basement can be significant. It can also be significant in the house, but most commonly in basements of the below ground.
So as far as the connection between that and cancer and screening and how much exposure you would need before you consider if it's actually affecting your lungs, or
Yeah, the risk of, it's in it.
what's the actual risk, I don't know how to organize all that.
Yeah.
From your perspective,
So from my perspective,
How much
you
should a
know,
person be concerned, or when should they see it?
so, you know, so I would, you know, I asked as a standard, I don't know what the normal, what the recommended period of time. You know, my guess is probably around 5 years, if you check the rate, you're the radon in your basement. My house actually had a mitigation system in it. And, you know, my wife and I decided, hey, we should probably check and see if this radon, if this thing's still working. The, you know, the house is now 20 years old. And sure enough, we checked it and it was not active. So they actually put a new system in the house, a more advanced system than we had had. And now our levels are down to negative. Now, how much radiation, how much, what's the effect of that radon as far as cancer cause, you know, the incidence of cancer? Much harder to separate out compared to like lung cancer. Why is that? Because when you're talking about the general population, 2 people can move from house to house. 3, the amount of time you spend in your basement has an impact. There's so many factors. I don't know if we can stand here and tell you that how many people a year are getting cancer, lung cancer from radon. I think the estimates are somewhere around 82% of lung cancers are radon related.
So if you find a lung cancer, are you able to tell if it's from a smoker or from radon or from metastasis from another cancer?
Yeah, so we can definitely tell it's metastasis from another cancer. Why is that? Because there's markers on certain cells. So like a pancreatic cell, when you have a certain marker on it, we call those antigen markers. So we can tell where the cell originated. So if we do a lung biopsy, there's something called a TTF, thyroid transcription factor. About 80% of adenocarcinomas, which is a common one. Adenocarcinomas are pancreatic cancer, esophageal cancer, gastric cancer, colon cancer, prostate cancer. Those are always called adenocarcinomas. We can tell the lung ones, 80% of them are TTF positive. Now, we don't just have that one antigen marker. We have other antigen markers that we used to, the better to delineate. But yes, if we biopsy something, we can tell you it started in the lung, it started elsewhere. We do treat those differently. If you have an isolated metastatic lesion, say with bone cancer, many times we'll take those out. You know, but we don't have to take all the lymph nodes and all that. Say they basically originate by going through the body and start pulling went through the bloodstream, lodged in the lung, so it's passing through. So we just have to take out that little spot in the lung.
Okay, and then if you have cancer elsewhere and do not have metastasis, it's all clear. Is there a general timeline as far as when that becomes an issue as far as metastasizing to another organ of your lungs or something? Or could that happen for the rest of your life where you would find then that, you know, 30, 40 years later, it shows up in your lung or somewhere else?
Yeah, unfortunately, it's different from cancer to cancer. So there are some tumors that can show up way down the line.
So breast cancer
Breast cancer can show up down the line. So
in the lung.
in the lung or elsewhere, yeah. So you get a breast cancer occurrence at 10 or 20 years out. Kidney cancer, very similar. You can get a renal cell carcinoma or kidney cancer. You can get out, 10, 20 years. I've seen that. The sarcomas are the same way. Soft tissue sarcomas and bone sarcomas that basically tumors of, like, say, the muscle, or tumors of the bone. We call those sarcomas, soft tissue tumors. Those can show up, 10, 20 years later. So it is variable from tumor to tumor. And that's why it's so important to keep those regular follow-up visits with your oncologist or with your breast surgeon or with your, your lung surgeon to make sure that they're appropriately following you. But each one of those, there's something called NCCN, which basically gives us our recommendations to physicians on how to follow everything. We follow those NCCN guidelines in theory from tumor to tumor. But you can look up just online. You just go in and put in NCCN guidelines for follow-up. And you just put the breast cancer, you put breast cancer, you put colon cancer, it'll show you really what your proper follow-up should be.
So I was just curious, I guess. So I was treated for breast cancer in '05 and did not have metastasis. And have not been back since for many years. So it's a long time. So when you talk about smokers and so on and all these criteria for lung cancer and so on, but where metastasis could have gone at any point, anywhere else in my body, pertaining to lung cancer, would there be something, is it a lab test, or would they do, I mean, would they look for that with no symptoms? Would I have symptoms?
You know,
Or
I
is it
think
any
at this point,
person?
you know, and I'm not aggressive, but I would say at this point, likely that you'd be back in the realm of just your regular mammograms, and regular follow-up. You know, I don't know that I don't think anyone's gonna be doing yearly CAT scans on somebody 15 years out, or in this case, almost, you know, we're 18 years out, 17 years out from breast cancer. I don't think anyone's gonna do CAT scans or anything like that. I know at this point, you're probably just gonna watch for symptoms and that, but they do get you back into your mammography and all that, because there's still a risk of you getting it, you know, at a second breast cancer, most likely, you know, still a breast tissue, there's still a chance of getting another breast cancer. So that's why sometimes, you know, when someone has a breast cancer, they'll actually sometimes take off both breasts because of the risk of lung cancer on the other side is so high that they do that. That's not for all patients, but that's for some. And some patients, you know, that there's a gene that they can look for, that BRCA gene. They can actually tell you that people like, you know, Angelina Jolie has had prophylactic bilateral mastectomies because she's BRCA positive. So she's at a very high risk of developing breast cancer in her life.
But if it did go to the long road, there wouldn't necessarily be symptoms, and the mammogram would show the lung.
No, it wouldn't, but you have to look at, you know, so there's a crossover there. What's that crossover? Is that, if you say, well, you know, you have issue of breast cancer, we're going to give you a CT scan from your eyes to your thighs every year for the rest of your life. Well,
No,
you know, right? There's the radiation exposure from the CAT scans. There's the findings that may be found that you follow up on that may not be anything bad, but there could be a complication of, say, a biopsy or something. So there's a risk benefit ratio, and at some point you can stop the screening and stop the scanning. We do the same thing. Like we put you back, we take you out of diagnostic scans and put you back into regular screening scans after 5 years because we don't want to expose you to too much radiation from the CTs.
I guess what I'm saying for me is the opposite. I have not had any follow-up since then of any kind.
But you're pretty, you know, the one thing you have had though is disease-free interval, right? You have no symptoms, you know, of disease for 17 years. So it's very unlikely you will currently have any cancer in your body, just by the fact that most people would succumb to it if it was metastatic at this point. So I think you can be pretty well assured that at least from that standpoint, the odds of recurrence are quite low. Not zero, but they're still quite low. And I'm not sure any screening would make a difference.
I have a question. We've talked a little bit about smokers and their, you know, possibility of getting lung cancer. Is any of that applicable, or what is applicable for people that experience secondhand smoke for a long period of time?
Yeah, that's a good question. So we do know that secondhand smoke does increase your risk of developing lung cancer. But the risk is not great enough to justify screening.
Okay.
So at this point, we don't justify screening. Now, would the day come when we quantify it better? And we would recommend it possibly, but at this point we haven't.
Sure.
You know, I had patients before. I had a long distance trucker, you know, come in and he had lung cancer, never smoked in his life. But the guy who he drove with did smoke. He smoked regularly in the cab. So sure enough, he got enough exposure from that secondhand exposure to unfortunately get a smoking related cancer. So it certainly is a risk factor, and I've seen it in my practice, but still not enough of a risk where you can say that there's a benefit to screening for it.
Is there any genetic links to this? Like if a parent has lung cancer, should you screen at a younger age, or is it
there certainly is a propensity to develop, lung cancer if you have a first degree relative who smokes. But if you're a non-smoker, that risk is not great until you're in that screening or anything along those lines. So are you at an increased risk if you smoke? Yes, that's some kind of genetic predisposition. And just like if you have a relative who gets emphysema from smoking, you're more likely to get emphysema if you smoke also. So it does increase your risk of developing cancer if you smoke. But if you're a non-smoker, your risk of developing cancer is quite small.
During some of the slides, you showed some pictures of some equipment. And I kind of wondered if all the hospitals in the area have the same advanced equipment like Washington.
No, so that's a good question. So,
some hospitals are called community hospitals or something. So who has the best equipment?
yeah, that's a good question. So,
And doctors.
and so, that may be up for debate, but it's pretty easy to quantify. So, to that point, robotic bronchoscopy that I showed you, that exists at Christ, that exists at University of Chicago, that exists at Northwestern. I'm not 100% sure about a Rush having a robotic bronchoscope, but that is something that is. Halos is not number one, little company is not number one, so Cross is not number one. I mean, it's a $750 million investment, and they just don't do enough lung cancer, lung nodules, and screening to justify it. Not that they're not great hospitals.
So how does a patient know where to go? If the patient's primary is on staff at a little company, what happens to that patient? How does he get directed to Christ?
Yeah, it's either that you acknowledge that, hey, this is a big cancer program, you come out to some kind of evening like this, and you really learn, hey, Christ.
That's a long shot.
but it is a little bit of a long shot about this, but it is an important reason to stay educated yourself. Because if your primary is affiliated with a little company, probably gonna send you to a little company. Not that little company's not a good hospital, it's a very good hospital, but the amount of lung cancer, those type of things treated is much less than at Christ, say. And then the amount of the ion and the safe and the cyberknife, those kind of things are not there because it's just too much money for a small hospital who's only doing a few cases.
Yeah, I got all that, but how does the patient know to select the right facility?
I think it's basically you have to rely on your primary to send you to the best place. I think you also have to do your own education. That education can occur on the internet and look up these institutions. And like to give you an example, maybe the best way I can point you is that for patients.
But the internet, what you read there is what's provided by the hospital.
So, certainly bigger is more experience. And in most places, you put a cancer report out. Okay, they have to like show their numbers to the American College of Surgeons who certifies cancer programs. So most of them put numbers out. You can get those online or from the American College of Surgeons and the American Cancer Society probably has too, but American College of Surgeons. You can go on and at the hospital, look at the cancer report and say, how many prostate cancers do they do at that hospital? How many breast cancers do they do at that hospital? And certainly when the numbers are greater, the expertise is great.
Where's a place like the high-tech medical park and all of those places factor into all of that?
So that's, most of those things are just diagnostic. So high-tech has diagnostic capabilities,
Maybe radiation.
but they do some radiation, right?
High-tech's a part of Christ.
I think it's affiliated with Advocate. I don't think it's really associated with price, but it's affiliated with Advocate. You're exactly right. So all part of the Advocate system. But high-tech's more of the diagnostic things, but like robotic bronchoscopes, radiation, those type of things, they're going to occur. Radiation occurs in high-tech, but as far as surgery, all those type of things, they're going to occur in a hospital setting, and that's Christ.
I have another question back to, how you have, privileges at all these hospitals. And I know back in a certain time, when you had a primary, it was really important that you had, that your physician had privileges at the hospital of your needs. In case, you know, you needed them to be there, they couldn't come see you unless they had privileges there. I've been hearing lately a lot about it doesn't matter anymore because there's a hospitalist instead, and it doesn't even matter if they have privileges there.
That's exactly right. So, basically, I guess that transition started occurring 15 years ago, and it's really come full circle now to the point where there's most primary doctors who see in the office do not go to the hospital. And why is that? That's really because two reasons. One, a lot of physicians are employed now, so their primary doctors may be employed by a little company, maybe employed by payrolls, and maybe employed by Price and by Advocate. And they may say, hey, they determined that it's more efficient for that doctor to sit there in the office, see patients in the office, and have another doctor take care of the patients in the hospital, because it's too inefficient for him to be running back and forth.
So is it still a benefit though to have, you know, that's great that you have all this privilege in these hospitals. Is that kind of an extra bonus to have that for the patient? Or
I see. Beyond other hospitals. No, the reality is that those things, those privileges really, for myself as a specialist who just basically does surgery, but they really just apply to my ability to give a consultation with somebody who calls up with a problem on the phone, and the ability to look at that patient's record and help them out. So we serve as a referral center, you know, for a lot of Chicagoland, and you know, we get people as far north as, you know, as far north as Wisconsin, and you know, many patients from Indiana. And when you think that the geography of the price is such that really you're going to New Chicago, you're going all the way up to Joliet as far as coverage for complex cases, and all the way down to Kankakee, then all the way north to the city where you have, you know, like Rush and something in the city. But I had a patient transfer to me within the last year by just truth of Illinois, transfer to me because really need for really expertise. So that's the purpose of being at those hospitals. It's really not that I'm going to go out there so much. It's more that I can be available to them if there's a question or something along those lines that we can, you know, better impact patient care. Some of those hospitals I'm not in are Advocate hospitals, some are not. And you know, I can, you know, help figure out to that standpoint. Because a lot of what we do is with the, you know, with our quaternary and tertiary care, the higher levels of care, you know, transplant, things along those lines, that we take care of at price to basically fill that need in our community.
So we're looking at the doctors that still can pursue the possible.
Well, one more time.
So looking, I'm looking for a new doc now. So is that still something worth pursuing, someone that has privileges at the local hospital?
You know, I think that an affiliation with the hospital you would choose if you were to go to the hospital, I think it's helpful to have doctors on staff there. Now, they may not go there and make rounds, but they're frequently on staff, so they have access to your record and all this stuff. So I think there is an advantage that your doctor, you know, whatever the hospital, you would probably get 90% of your care at. It's good if the doctor, your primary doctor on staff at that hospital. Now, if they're going to come there around, and they're likely, they may use a hospitalist, but more importantly, they have the ability to look at your record.
I understood that the records are within the hospital system, and any doctor that's within that hospital system can access those records.
That's exactly right. Anybody within the system. So if the doctor's on staff at the hospital, they can access it. But you know, give you an example. I'm not on staff at. I'm not on staff at. I am not on staff. I'm not on staff as well. I cannot look at your record. There's something about Epic Everywhere. They are Epic. I can look at your Epic Everywhere chart. I cannot see your actual rush chart, which has much more information, the actual pictures, those type of things. So, so there is a real nuance there that if your doctor is on a damn hospital, they have access to the entire chart, the entire history, X-rays, everything else. So I think that association is great. That's not to say that doctor is gonna come see you in the hospital. That's not an common thing. But if it is important to you that doctor see you in the hospital, those doctors still do exist. And it's just a matter of probably the best thing to do is call it physician services. And say you're gonna choose price, you're gonna choose Palos or something, I guess with physician referral line and tell them you want a doctor who's on staff there and who makes rounds at the hospital on some patients within the group. And there are those doctors who still exist, but maybe
I don't know that are private. Private.
some of them are private care, some are older associated doctors. So there are still some older associated doctors who still go to the hospital. And so they get that physician referral service can help you out.
So hospital is calling the shots for the person's care, right?
They are, right? In the hospital, they have
The
all
guy
the
you
shots.
don't know. And doesn't know you.
Well, not for long. They just met you.
I'm sorry?
But you're right. They have not known them long. And they do get to know you. They take your history. They do their physical exam. They get to know you, but they have not known you as long as your family doctors know you. That's for sure.
So it doesn't make any difference. It's in the same primary forever. He's not gonna make any decisions
If you're
about my care.
so.
With the hospital.
So I think there's a big advantage if you have a family doctor you've had for years and years. And that is simply that you can rely on his input. Even if you're in the hospital, you can call the office and say, you know what, they want to take out my appendix. Should I let them take out my appendix? And that doctor can give you his thoughts on, well, let me talk to that doctor, let me talk to this doctor, I'll get back to you and let you know if I think they should have your appendix. So there's a big advantage, I think, in having a doctor, your doctor. And so I would say that even though your doctor cannot come out there and do at the hospital, you still have the ability to reach out for the guidance. And they know they know you well, they know when to send you to the hospital, Bill never complains of pain and always complains of pain. If something's very wrong, you should go get checked out. So I think there is an advantage whether a doctor goes to the hospital or not, having a regular doctor. And don't feel reluctant to reach out to your doctor if you're in the hospital and you're concerned about what's being done. That's part of the point of having a doctor for years and years. They know.
Let me tell you. My wife was in the hospital for something. We were waiting for the hospital. And who shows up? Who shows up at the hospital is an elderly woman who looked at me, who was tired or semi-tired, put in some time to go home. Yeah. This is not right. Is that right?
Yeah. Well, I think if you want, you have to.
Well, I'm saying.
Yeah,
So,
you can just say, hey, if you meet her,
well, I didn't know that, we were on our way.
if you're not confident about it, you can always ask for another hospitalist. Once again, you can always call your family doctor, say, hey, you get signed this hospitalist. I'm not really happy with it. Can you weigh in or talk to this doctor? I want to make sure they're doing the right thing for my wife. But don't be afraid to ask for another opinion from another hospitalist, like the one you're getting. And don't be afraid to reach out to your own doctor. That's why they're there. All right. Thank you so much. I appreciate all your time. Thank you.
Thank you.
I shout out there for Sandy ran